Thank you for the invitations for me to speak on this topic, Practical Guide in Epilepsy Treatment. I am Professor Lim from University of Malaya, Malaysia. These are the principles of management that I use in managing epilepsy. And I will start with first seizure. So let's start with case number 1, when to start anti-epileptic drugs. So this 30-year-old man had the first episode of generalized tonic-clonic seizures, and clinically there is no focal neurological deficits. CT brain was normal, biochemistry screening was normal, and EEG was also normal. So would you start anti-seizure or anti-epileptic drugs for these patients? Well, the diagnosis for these patients first unprovoked seizures. So based on ILAE 2014 definitions of epilepsy, someone with at least 2 unprovoked seizures will be diagnosed as epilepsy. However, if someone had only 1 unprovoked seizure, but the recurrence risk is 60% and above, we can also diagnose these patients as epilepsy. So how are we going to calculate the recurrent risk? So based on this study in 2013, is someone unprovoked seizures has no known factor, which we call idiopathic, the chance of having another seizures is around 0.4, which is 40%. However, if the seizure has a known cause, whereby if the patients have abnormal scan, we will call this remote symptomatic seizure, and in this case, the risk of having another seizures will be more than 60%. Therefore, the option will be, if the cause is idiopathic, we will wait. If there is remote symptomatic cause, we will start anti-epileptic drugs. However, if this patient have another seizure, based on this graph, if someone have second seizure, the risk of having another seizure will be more than 60%. And therefore, anyone with 2 seizures and more should be diagnosed as epilepsy and start anti-epileptic drugs. However, if someone having no seizure within the first year, the chance of having another seizure will be much lower. So the risk of recurrence is higher in the first 2 years. As you can see here, the risk is about 30 to 40% in the first 1 and 2 years. However, after 1 year of seizure freedom, the risk will drop to about 10%. Therefore, if someone having only 1 unprovoked seizure and we follow up for 1 year and there is no more seizure, the chance of them having another seizure is very low. This is a very simple guide to be used to predict the risk of seizure recurrence after 1 single seizure. So if you can see on the starting value, if someone having 2 or more seizures, we will score them as 1, 4 or more will be 2. However, if someone having neurological deficits, developmental delay, or learning disability, there will be 1 abnormal, EEG will be 1. So if anyone who score 1 and above, the risk will be either medium or high if it's 2 to 4. The risk of seizure recurrence by 3 years or 5 years will be more than or around 60% for those with high risk or with a score of 2 to 4. Whereas for those who score only 1, the probability of seizure by 5 years is 56%. And therefore, if someone having a score of 2 and above, we should start treatment, and someone having a score of 1, we should inform the patients of their recurrence risk, which is around 50% in 3 years and 56% in 5 years. To make it simple, usually we use a guide as follows. We know that about half will not have recurrence after the first seizures, and that's why we don't usually start treatment when someone having first unprovoked seizures unless they are having a higher recurrence risk as follow. For example, if they are having abnormal brain, city brain, abnormal EEG suggestive of focal or generalized epilepsy, having a positive family history, or patient have 2 seizures or more, or night seizures, or having cognitive developmental disabilities. However, most of the time, we will discuss with the patients about the risk and let them consider whether to wait or to start treatment accordingly. So which anti-epileptic drugs to use when we are considering treatment? There are a few principles of management when we want to choose the first line anti-epileptic drugs. First of all, we want to make sure the seizure is controlled, and secondly, we want to make sure there is minimal side effect or patient can tolerate the medications well. To achieve this, most of the time we will try to use monotherapy. There are many factors to be considered, either the drugs-related factor, patient-specific factors, or nation-specific factors like drugs availability and cost. However, recently there is an online tool which is called EpiPick to guide you to choose the appropriate anti-seizure medications in patients with epilepsy. And you can click the link or type the link in your Google Chrome to reach this drug selections tool. If you want to know further information, you can go to my YouTube link and look for personalized medicine in epilepsy lecture. And there is illustrations on this tool. So why are we using monotherapy? Usually, monotherapy will have better tolerability. They are simpler and easier for the patients to follow, better compliance, no potential or less drug-drug interactions, and lower costs. And how do we choose which anti-epileptic to use? It's usually based on evidence rating criteria. And the rating criteria used in epilepsy are usually non-inferiority, which means the drugs is not poorer or worse than the primary choice, which is usually carbamazepine for focal epilepsy. And based on these comparisons, we can divide the trial into class 1, 2, and 3 level of evidence and level of A, B, C, or D of recommendations. And you can see here, rule number 1 that I usually follow is the evidence. For partial onset seizure, or now we call focal onset seizure, there are a few level A recommendations, which include carbamazepine, levetiracetam, phenytoin, and zonisamide. Whereas for juvenile myoclonic epilepsy in 2013, there is only level D recommendations, which is topiramate and sodium valproate. However, sometimes we can choose the drugs based on seizure type. And you can see here, the sodium valproate has a broad spectrum similarly to lamotrigine and topiramates, which can be used to treat both focal and generalized epilepsy. Whereas for carbamazepine and phenytoin, they can aggravate myoclonic jerks and absence seizures, and therefore it is only recommended for those with focal epilepsy or generalized tonic-clonic seizures. Rule number 3 is to follow guidelines, and this is a Malaysian consensus guideline in 2017. And you can see here, we have recommended a few monotherapy for focal seizures, which include carbamazepine, lamotrigine, levetiracetam, oxcarbazepine. Sodium valproate in high dose can still be used for focal seizure, and the last is zonisamide. And the last rule is to keep it simple. So in generalized epilepsy, usually I prefer sodium valproate unless it's contraindicated. For example, in women with childbearing potential, or in focal epilepsy, I usually will prefer carbamazepine unless the patient has positive HLA-B1502 or other contraindications. We will only consider newer medications when the first line is not is not suitable or contraindicated. And the newer medications which are usually preferred is lamotrigine or levetiracetam. So principal management rule number 2 is to start low and go slow. Most of the time, you start with very small dose and titrate gradually. And gradual titrations is needed for most anti-seizure medications. However, to achieve a better seizure control, we usually aim total seizure freedom with maximum tolerable dose. So the dose will be titrated up until we have achieved seizure freedom or the maximum has been achieved. Seizure diary is useful for assessments of response, and always remember whether the patient is compliant to the medication or not. If first anti-epileptic seizures fail, consider another monotherapy rather than combinations. If I want to tail down the first seizure medications, I'll do it gradually unless patients develop idiosyncratic side effect or allergic reactions. I seldom do drug monitoring. If I do, I'll use it mainly to assess efficacy, toxicity, on compliance. As we know, the efficacy of first seizure medications is about 47%, and second is about 13%. And therefore, if someone has failed 2 seizure medications, the likelihood of patients' response to the third and fourth seizure medications is lower. Nonetheless, I will always try more before considering epilepsy surgery. In any refractory cases, remember to revise the diagnosis again. And sometimes the non-responsiveness is related to wrong diagnosis. Some of them may be having non-epileptic disorders or wrong syndromic diagnosis, and some of them may be having poor compliance. You may refer the lecture by Dr. Ria on epilepsy diagnosis. So let's try with case number 1 on generalized epilepsy. This 16-year-old girl had 1 episode of generalized tonic-clonic seizure in school. She was given phenytoin by the general physicians and developed early morning myoclonic jerks after the use of phenytoin. The EEG showed generalized polyspikes and wave. So, what is your diagnosis? Do you want to start anti-epileptic medications? If yes, which one do you want to start and for how long? So let's take a moment to think about this case, and I will give you the answers later on. So this patient has juvenile myoclonic epilepsy because the onset is at juvenile age, and the patient had myoclonic seizures with generalized tonic-clonic seizures. The seizure of juvenile myoclonic epilepsies are usually well controlled in 90%. However, remember, the use of anti-seizure medications must be long-term. There is a very high recurrent risk up to 70% if we withdraw anti-seizure medications. So do you want to start anti-seizure medications? Answer is yes. And usually for juvenile myoclonic epilepsy, which is generalized epilepsy, I will use sodium valproate. However, in female with childbearing potential, be careful. If someone who is still in studying, or they are not having a plan to get pregnant or get married, I will normally consider sodium valproate first. However, if the lady has already married and had a plan to get pregnant, then we have to choose other choices like levetiracetam or lamotrigine. Remember, carbamazepine and phenytoin may aggravate myoclonic seizures, and in juvenile myoclonic epilepsy, most often I will try to give lifelong anti-seizure medications. But sometimes some patients may prefer to reduce the dose or stop after 2 years seizure freedom. So for pregnancy and epilepsy, you may refer to Dr. Kunia's lecture later on. Case number 3, focal epilepsy. So this is a 40-year-old gentleman with temporal lobe seizures presented as oral automatism and left hand dystonia. So the diagnosis is right temporal lobe epilepsy, which is a focal epilepsy. So what anti-epileptic drugs that you would like to start, and what is the chance of seizure freedom with first agent? So to keep it simple, remember, focal epilepsy, we always consider carbamazepine, but there are other choices that you can use like levetiracetam, phenytoin, and zonisamide based on the evidence. Based on the guideline, there are many more other choices, including lamotrigine, oxcarbazepine, and even high-dose sodium valproate. In these patients, or in Malaysia or Indonesians, we always consider HLA-B1502 alleles. If it is present or positive, the risk of Stevens-Johnson's is higher. And this was first described by Chong in Taiwan patients in 2004. And therefore, in my practice, if someone come to me for first seizure or recurrent seizures, which I suspect focal in onset, I will normally send the HLA-B1502 while I'm doing EEG and MRI for the patients. And when patients come back for the second clinic consultations, I will check their status. If the HLA status is negative, then I'll start carbamazepine. If it's positive, I will avoid carbamazepine. However, nowadays, if the HLA-B1502 is not available in your center or in your hospitals, you may consider counsel the patients for the risk of Stevens-Johnson. Start with small dose of carbamazepine and remind them to stop if they develop any rash or oral ulcers. How about stopping anti-seizure medications? So let's say someone who has started a seizure medications, when do you consider to stop that particular drugs? There are a few reasons. First, if the medication doesn't work, which is failure of response. If the patient has achieved seizure remissions for 2 years or more, or if the patients develop intolerable side effects to the medications that was given, or patient is considering pregnancy and the drugs is teratogenic. You can refer this few lecture. First is Managing Epilepsy in Remissions by Prof. Ernest Somerville, or Managing Anti-Seizure Side Effects by Professor Emilio Peruca, or Managing Epilepsy in Pregnancy by Dr. Cunha. And I would not cover in details on these few topics. Now let's go to the third sections of the principles, which is the newer anti-seizure medications. When the first line is not working or contraindicated or not tolerable, we have to know the newer drugs in order to choose the best option for our patients. These are the medications that is available according to the years, and prior to 1990, we call that first generations, followed by the second generations until year 2000, and the third generations, which is after year 2000. In Malaysia, we have zonisamide, pregabalin, nicosamide, perampanel. And the newer medications is different from the older medications, either because they have novel mechanism, like levetiracetam, perampanel, nicosamide. They have broader actions, like lamotrigine, topiramate, or zonisamide, or they have less side effects, like oxcarbazepine compared to carbamazepine. However, we must understand that the efficacy of the newer medications is not much different from the older drugs. In this chart, you can see the top half is the enzyme-inducing and medications such as carbamazepine. And the lower half is the newer medications, which are usually non-enzyme inducers. And the chart on the left is for 50% seizure reductions, and the chart on the right is for seizure freedom. As compared, the newer and the older medications has no significant difference in terms of seizure response or 50% seizure reductions or seizure freedom. Therefore, how are we going to choose the newer medications if the first one doesn't work? This is a way I usually do. It depends on the efficacy of the medications and tolerability. Usually, levetiracetam and nicosamide is much preferred because of its higher efficacy and better tolerability. However, in certain instances, for example, depressions, we will try to avoid levetiracetam. Whereas in other instances, we will choose lamotrigine or zonisamide because they are cheaper, although the efficacy is lower than levetiracetam or nicosamide. At times, we will choose topiramate and perampanel and go even to the highest dose when the seizure is not very well controlled. Although we know that topiramate and perampanel has a lot more side effects, including sedations, drowsiness, and sleepiness. These are the common side effect profile. This is not a complete list, but remember, accordingly, it will help us to manage the patients, especially on the use of newer seizure medications. Firstly, for carbamazepine, I always talk about GGT, which is liver enzymes raised in carbamazepine, but this is because of the enzyme-inducing effect. And therefore, even the GGT is high, we don't normally stop or reduce carbamazepine. Secondly, carbamazepine can cause hyponatremia. If this is symptomatic or if the hyponatremia is severe, then we should consider reducing carbamazepine. Sodium valproate have many known side effects, including weight gain, tremor, and in women, polycystic ovarian syndrome and teratogenicity. And therefore, we always monitor the weight and tremor when we are using sodium valproate. Lamotrigine will be Stevens-Johnson, and remember to reduce the risk, we should titrate the lamotrigine in a slower rate. Topiramate and zonisamide has various similar side effects, including renal stone and glaucoma. And remember, some of the patients may develop naming difficulties and weight loss. Levetiracetam is known to cause irritability, especially in young patients and also in those with depressions. For perampanel, some of my patients having difficulty to wake up in the morning, and that's why I use a very small dose in Asians, as low as 1 milligram daily. If they cannot tolerate that, I may even use 1 milligram every other day. Sometimes combination therapy is much better. The known one is sodium valproate and lamotrigine. which have a synergistic effect. Parenteral was also shown to have a better seizure control when it was given together with sodium valproate. The last of the principles will be epilepsy surgery. In order to choose the suitable case for epilepsy surgery evaluations, there is a simple online tool that you can use. And this tool assesses various factors. For example, how many seizures, the type of seizures, and whether the patient's seizures are controlled and how many seizure medications the patients are on. And based on these factors, there is a recommendations whether you should refer or not to a center which can do epilepsy surgery evaluations. You can refer to my YouTube again on personalized medicines in epilepsy on how to use this online tool to select surgery candidates. So in conclusions, the most practical guides that I always recommended is to follow the evidence. Second, to follow the guidelines, keep it simple. And sometimes if you are in doubt, you can choose online tools to help you to pick the first seizure medications using EpiPick, or consider epilepsy surgery referral tool when you are considering epilepsy surgery. Thank you for listening.